Did you know women are 2.5 times more likely to be diagnosed with depression during the menopausal transition than before menopause? And these are just the ones that are known. The number may actually be quite higher. Hi, my name is Anita Kaiser, and this is episode 7, the final episode of the podcast series Menopause and SCI in a Hot Flash, where we'll talk about mood, cognition, and sleep disorders as they relate to menopause. Joining me is my colleague Margaret Conquest, who has over 34 years of experience living with a spinal cord injury, and our guest, who is a subject matter expert, Dr. Abe Schneiderman, who is the director of the Neuropsychiatry Service in the Brain and Spinal Cord Injury Program at Toronto Rehabilitation Institute, University Health Network, and the associate professor in the Departments of Psychiatry and Medicine at the University of Toronto. Welcome to the show, Dr. Schneiderman.
Thank you so much for having me. It's a pleasure.
So I'd like to start first by talking about cognition, as this is an area that I feel has really affected me in recent years since experiencing menopause, and especially the difficulty with focusing for long periods of time, remembering things that I have to do and forgetting words when I'm speaking to someone, or even when they tell me their name, 2 seconds after that, forgetting what their name was. What are some of the most common memory or cognitive issues that women report during menopause? And are there any that are SCI specific?
Thank you for the question. It is a very common question that people of a certain age complain of in my practice. Now, specifically when it comes to menopause, and let's put spinal cord injury aside for a second. The most common complaint is a slow of the processing speed. In other words, you might know what you want to say, but it takes you a while to retrieve the word. That is followed by issues with attention. So in your case, when you try to remember somebody's name that you just met, you might have been anxious, you cannot remember the name. So that's attention issue, not memory. The third is executive dysfunction. And by that, I mean issues with planning, organizing, decision-making, problem solving, which menopause might intensify, having difficulties with these issues. Lastly, are the issues of memory itself. There's several types of memory, working memory, which you use every day. So remembering how you brush your teeth and remembering what your address is. And then short-term memory, which is information that comes in and out very quickly that you might not need long-term. That particular memory function that we see quite affected in menopause, and whether that is related to age or the menopausal changes is hard to tell. Now, in spinal cord injury, we see that more frequent, and we're not exactly sure where that comes from or why that is. We know that estrogen is a hormone that helps with neurotransmission in the brain, with how the cells communicate. So as estrogen peters out in menopause, some of the functions of the brain are also slowed down.
The cognitive stuff has probably been the hardest for me. And you really painted a picture of me in what you just said, Dr. Schneiderman. It's scary because I feel like I'm such a diminished sense of myself, and my confidence in my abilities is lower. I have difficulty remembering, carrying out a sequence of tasks, and retaining new ideas and new learning. I used to feel broken, and I still feel like I'm not the same person that I was now that I'm 3 years in. Is brain fog during menopause a sign of dementia?
Margaret, do you want the good news or the bad news?
I like it all. I'm a realist.
Awesome. So the good news is that definitely not. There's plenty of research demonstrating that brain fog, so to speak, is not a sign of dementia. It is a sign of hormones being dysregulated, being not necessarily at the levels they should be, and their effects on the body. However, there are also other issues that might be contributing to this. So if you have hot flashes and you're not sleeping, or if you have sleep apnea and you're not sleeping and you're not feeling rested, if on top of that you are having other exacerbation of symptoms of spinal cord injury because of menopause, vaginal dryness, bladder and bowel issues, and you are preoccupied by it, you're not relaxed, you're inattentive, you're irritable, all of those things contribute to quote unquote brain fog. Brain fog tends to be temporary and related exclusively to hormonal changes. The person was perfectly fine, started menopause, brain fog started. After a few years or months, depending on each person, it tends to ease off. The typical brain fog is difficulty with word finding, forgetting names, numbers, appointments, having problems focusing, feeling very tired, very sluggish. In dementia, if you forget what to do with a fork when they hand you a fork, that is a problem. If you forget the name of the waiter, that is not a problem. If you forget whether you turn off the stove or not, and you turn around and you realize you do, that's not necessarily a problem. So it's a matter of degrees. It's a matter of timing when the symptoms started. It is, as I said, temporary, improves after menopause subsides, can start in the perimenopause, managing some aspects of your sleep, of your mood, managing anxiety, and managing hot flashes will likely have a positive effect on the sort of called brain fog. Now, for the bad news, we don't know exactly why it happens, but that's not really bad news. It's universal and it happens to almost every woman going through menopause, spinal cord injury or no spinal cord injury.
At least now we've acknowledged what brain fog is, and it is real. And unfortunately, there could be a number of issues that you said could be contributing to it. But what are some of the simple things that women with SCI can do every day to help their brain fog? Like, you mentioned a few things, and I find like for me, like writing everything down is helpful because if I don't, I'll forget it for sure. And I find I often need to take a lot of micro breaks while working because I get a lot of brain fatigue. But what are some of the other helpful tips that can help women who are experiencing this?
A very easy way of remembering what you can do to try to preserve cognitive function in general is that whatever is good for your heart is good for your brain. So we all know that you need to exercise. We need to keep your blood pressure low. If you have high blood sugars, you need to control it. If you need medication, you need to talk to your family doctor about what the right dose is, which medication you're taking that might have an effect on your cognitive status. For example, some of the bladder medications that people use because of bladder instability can have an effect on memory encoding. So cardiac health, heart health is brain health. Nutrition, very important. You eat well, you don't overdo it with alcohol, or you tend to avoid alcohol if possible. You don't smoke, you try to exercise, prioritize sleep. Now, that's easier said than done. But when we sleep and we go into deep sleep, your memory starts getting filed. So the memory that registers during the day during deep sleep gets filed, and that is very important. So that having a good night's sleep or as good a night of sleep as you can. And then there's the one that's the most complicated to manage, which is stress reduction. Now, Snyderman, how on earth to manage stress? If I had the answer, I would go to Sweden and collect the Nobel Prize. But simple issues. We live in the here and the now. You don't guess what's going to happen in the future. The feeling that you are in control of anything, it's a fantasy. More often than not, we are in control of what we wear that morning, and that's about it. The rest is just capacity to adapt. So realizing that stress is a killer of brain function, managing stress through mindfulness, breathing exercises are fantastic. Don't believe me? Try it. Breathe very deeply for 30 seconds, focusing just on breathing in, holding your breath, breathing out, holding your breath. Do it for 30 seconds, see how you feel. Now, when it comes to spinal cord injury, this is where it gets a bit tricky and depends on the level of the spinal cord injury. But exercise, and I'm not a physiotherapist, I'm not that smart, so exercise is crucial. Physios are very good at giving exercises and monitoring exercises to patients surviving spinal cord injury. So as much exercise as you can so that your heart rate goes up that's good enough for your brain, that's good enough for your heart. Memory aids. I am iffy about memory aids. Yes, everybody has a smartphone that these days are smarter than I am, and I don't even know how to handle them. But if you depend too much of an aid or a memory aid, our memory skills start shrinking. So everybody now uses speed dial. And when you ask what's the phone number of your friend, when you've been speed dialing all along, it's hard to remember. So yes, use memory aids, but learn something new, something that will challenge your brain. And if you find that that doesn't help, seek help.
Wow. So that's quite the list. And some I have actually incorporated. Some I'm going to check in on a little bit more. It seems overwhelming, but they're all fairly doable. So I actually had the distinct pleasure of transitioning immediately to menopause because of surgery. And
Oh
my
dear.
cognitive symptoms were pretty immediate and distressing. My doctor absolutely noticed it because I've been with the same person for about 15 years. So they noticed it. I was able to speak about it right away. I know it's more subtle onset for others. When should women go see their doctor about brain fog? And what can they do to help their doctor help them?
It's a question I get often, and I usually turn it around and ask a question myself. If you had chest pain and you've never had chest pain and you started noticing chest pain for 3 days, would you tell your doctor about it? The answer
Fair.
is yes. So
Yep.
what we're dealing here is not really when you're going to talk to your doctor. We're talking about stigma, embarrassment. I don't want to be seen as dumb. I don't want to be seen as crazy. I don't want to be seen as incapable. So I'm going to shut my mouth, say nothing about it, and suffer in silence. When in fact, the moment you notice any issues that affect your general function for more than a few days, say more than a couple of weeks, talk to your doctor. It might be menopause. It might not be menopause. It might be anxiety, depression, insomnia. You might be developing a urine tract infection that starts to develop into a bit of a problem. You might have a pressure sore that you might not be aware of that starts to become a problem. Anything that affects the body in spinal cord injury affects the brain. Think of it, if it was my chest hurting, would I seek help? The answer is yeah. So it's the same. Brain function is the same as mind function. So treat the main organ in our system accurately, respectfully, and forget about shame and stigma. There's nothing to be ashamed of.
Yeah, some great suggestions. So I want to switch gears a bit and talk about mood because, as I mentioned at the start of the show, there's a high risk of depression as women go through menopause. And I know I find myself sometimes experiencing anxiety attacks or just anxiety in general getting worse. So, why do some women experience sadness or increased anxiety with menopause?
I'm sorry you're going through that, Anita. It is very hard. People who've never had a panic attack don't understand what it's like. It's not fun at all. The easiest garden variety response is because of hormonal changes. And that's a kind of a duh, Dr. Snyderman. Well, of course, it's hormonal changes. But it is important. Estrogen and progesterone drop during menopause. That affects chemicals in our brains called neurotransmitters that are typically associated with maintenance of mood, decrease of attention, focus, concentration, and general brain function, so to speak. When these compounds, these hormones start dropping, though they're not exactly neurotransmitters, they don't really communicate in between cells, they foster the communication between parts of the brain. Some of those parts are the ones that mediate, that regulate mood, sleep, appetite, energy, all of the primitive functions, so to speak, quote unquote, primitive of our brains, sort of the reptilian brain. And part of that has to do with mood regulation. Then there are issues with sleep disruption, as we were talking about before. When your sleep is not restorative, not long enough, or not deep enough, inevitably your mood starts to become affected, and vice versa. If your mood is affected, perhaps the number one thing that goes is sleep. You start ruminating, worrying and worrying and worrying. Your sleep goes down, your mood goes down, your energy goes down. You start worrying about not sleeping enough. You start noticing brain fog because you're so sleep deprived. And then in the middle of it, you get a hot flash. Not fun. So the next thing is the psychological aspect. People who go through menopause, and I'm going to exclude Margaret, which is not the quote-unquote artificial or medically induced menopause, but normal menopause happens in the 5th or 6th decade. That's the time of major changes in our lives, life transitions and stressors, questions about longevity, questions about health, questions about our roles in society, questions about our own self-esteem. We don't look as good as we look when we were 21. I call it the age of the metal, silver in our hair, gold in our teeth, and lead in our feet. That's a big transition. There's emotional changes that can affect how we deal with life. The next thing is that if you have a family history of depression or a personal history of depression and anxiety, automatically puts you at risk. Doesn't mean you're going to develop it, but automatically puts you at risk. So if we have hormonal fluctuations, chemical changes in our minds, sleep disruption, appetite disruption, energy disruption, stress in our environments, stress in relationships, and you bring in a vulnerability towards depression because it's genetic, you have the perfect storm to get mood changes. Now, the vast majority of women go through some changes in mood without necessarily going into a severe depression. A minority of women will go on through develop a severe depression, and typically they had a history of depressions before, but it can happen what we call de novo, means new onset.
Yeah, I can see it's really like a vicious cycle or a ripple effect where one contributes to the other.
Yeah, it's one of those things that women don't talk about because it is stigmatized. Once again, we use the analogy of the heart. And by the way, poets were wrong. Feelings are not in our hearts, they're in our brains. So there's so much for my romantic self. So if you think about brain like heart, if you have any mood issues, which is brain function, don't ignore it. Talk about it. Seek help. Nobody's going to think that you're exaggerating or they're not valid. They're 100% valid and normal. The vast majority of women that go through menopause have mood changes.
So I think you've actually answered my next question, but we'll still ruminate on it a little bit. My mood swings, they kind of ended when menopause happened for me, but perimenopause was a real big shift. And I have to give my husband kudos because he handled a lot of ups and downs. The thing that has stuck with me, though, in postmenopause is anxiousness and anxiety. You had just mentioned a few minutes ago related to vasomotor symptoms, so hot flashes and night sweats that I still have from time to time. And then when brain fog amplifies because of sleep issues that go on for more than a night, you said if it's bothering you for more than a little while, more than 3 days, go and talk to your doctor. Is there anything else to add to that advice about signs that mood changes may be more than just feeling down?
Yes, there are, Margaret. Okay, I'm going to reveal a secret about medical practice. This is between us and the audience. Nobody else needs to know. If a group of symptoms do not alter your function, group of symptoms is a syndrome. If you're still functioning, maybe not at 100%, but you're still functioning, is not a disease. They're symptoms only. In depression, if your functioning goes down in any sphere, in any aspect of your life, for more than 2 weeks, consistently, more days than not, then that's a concern. So let me give you a bit of a list of what to look for. Persistent sadness or anxiety that lasts more hours of the day than not for more than 2 weeks. Mood swings that feel unpredictable, that are not typical of your personality, loss of interest in activities you normally enjoy, low energy, fatigue that doesn't get better even when you rest, sleep problems that could be too much sleep you have no energy, you're sleepy all the time, or not enough sleep, and problems coping with daily task of living. But the killer, what you really need to look into, is thoughts of lack of worth, hopelessness, guilt, feeling like a burden to others, thoughts of death. Those are red flags. So any of those symptoms, I would urge the audience to talk with their medical professionals.
That's excellent. It's really practical and clear delineation.
So, for those of us who do struggle with depression, anxiety, and mood swings, do you have any advice on what we can do every day to help our mood?
Yes. The first thing you need to do is recognize that you have a problem. If you don't think you have a problem, then you have a problem because you're never going to seek help. So we call that insight. So you need to understand that what you're going through is not normal. It's understandable. It might be related to an external factor, but it's not normal. That's number one. Number two, it's very useful to keep a mood tracker, a mood journal. Doesn't have to be a novel. It just has to be on a calendar. These days, you started feeling unwell, you started feeling low. What was happening in your world? What was going on? Write down what is it that you're feeling. Write down whether you're sleeping, whether you're eating, what's your energy level like. It is important to also realize that many people who survive spinal cord injury need a number of medications to function. Some of those medications can mimic depression, can mimic fatigue, can mimic anxiety. And so it's important to consider that as a reason why you might not feeling as energetic or maybe even low. Some medications actually can cause depression. Talk to your primary health provider. Bring the list of what you're feeling. Bring the list of when you started, your list of medications. And if you're new to their practice, your history of spinal cord injury. When did it happen? How did it happen? How long ago? How do you manage it? What are the current problems you might have? Very easy. If you feel sad for more than a week, a flag should go up. Now, some people do not necessarily feel sad. They get irritable. They get impatient. Now, those are mostly guys like me who are not as sophisticated and cannot calm themselves to say, I'm sad. Instead of getting sad, they get angry, they get irritable. But it can also happen in perimenopause, postmenopause, in people who have sustained spinal cord injuries. So realize that there's been a mood change. Talk to the people around you. Have they noticed something? Now, that's a hard one because nobody wants to hear, yeah, you're kind of moody or grumpy. But it is important. What do other people see? Think of the automatic pilot of the brain. What are the features our body presents with that even lesser animals like reptiles have? Sleep, appetite, energy, sex drive, attention and concentration, all of those functions, by the time they get affected, your mood is probably already on the way down. So that's a red flag. If any of those, what we call neurovegetative functions, get affected, really seek help. Exercise. If exercise is not enough, if despite exercising, abstaining from alcohol or recreational substances, managing your medications, your mood is still not perking up, you need to talk to somebody. It might be as easy as finding out whether there's something else happening in your system. How is your thyroid? Are you having an infection somewhere? Are you having a hormonal imbalance other than menopause? That might be very easy to correct. Can your medications be adjusted? If that is the case, and your family physician or your nurse practitioner thinks that no, everything is checking out, maybe hormone supplementation is needed. And that might be all you might use to boost your mood back up. However, if it goes on for a certain amount of time, more than 2 weeks, and you're not functioning, you might need professional help. You might need either medication, talk therapy, mindfulness, and other aspects that we might talk about later. The main message is do not ignore it. Do not assume that, well, this is normal. No, it isn't. Check it out.
So there's so many things that affect each other. I feel like you've really touched on the next question I was going to ask you about going to your doctor, and in the appointment, you had mentioned keeping track of your mood and keeping track of how long something is distressing or impacting you. Is there anything else that I can do to help my doctor help me when I go talk to them?
As a physician, I can tell you, I love the patients that bring a bullet point list of what is bothering them, and they give me a succinct one-pager of medical history if I don't know them. That saves me time, saves them time, and I also like when they bring their questions. I might not have all the time in the world to go through all of them. Talk about
Awesome.
what is more important. The next thing is our bodies have rhythms, hormonal rhythms, all the time. If you are able to get into a routine, and when people get depressed or very anxious, those rhythms fall out of pace. So the routine, you go to bed really late, you cannot sleep, you might be waking up too early, you're not functioning. So all of those routines go out of the window. So start with a routine, say in the morning. You know what you're going to do. You wake up, you get out of bed, you brush your teeth, or whatever is your routine, and follow it. Exercise. I'm going to sound like a broken record on this podcast, but exercise, exercise, exercise. Crucial, as much as you can. I don't care what it is, but as much as you can, because there is a direct connection between our muscles and our brains. And it's not just through the spinal cord, it's also chemicals. So it is important. It makes you feel good. And again, heart health is brain health. Stimulate your brain. How can we do that? Either you learn something new, you challenge yourself, or try to do a simple exercise like Sudoku, or a movie that might be a bit challenging but forces you to pay attention. Social contact is crucial. We are social animals. When we get depressed and anxious, we tend to isolate. The more you isolate, it's a vicious cycle. The more you get low, the more you feel that you become a burden to others, guilt, shame, and again, stigma kicks in. So connect to others. I can guarantee that you're not alone in this business. Sleep should be a priority. I cannot emphasize exercise and sleep enough, because that is where our brain starts cleaning all the debris. During our sleep, our brain starts doing a cleanup. So all of the information that doesn't need goes out, and some hypothesis is that that's why we dream, to get rid of pieces of information. But there's also actual cellular debris that gets cleared. Crucial to have a regular sleep-wake cycle. I urge the listeners to look in the internet for cognitive behavioral therapy for insomnia, CBTI, or just Google sleep hygiene. And they're very, very interesting tips there that are easy to carry out. If you are into journaling, fantastic. If you can do mindfulness, yoga, learn to be in the here and the now, learn to let go of the fear of not being able to control things, that goes a long way. And as I said before, talk to your medical practitioner about medications and medication side effects. Many of the medications that we use in our practice can have mood effects and brain effects, and we're not really aware of them unless we raise the issue that I'm feeling brain foggy, my mood is not great, I'm not sleeping well, or I'm sleeping too much, my appetite has changed. The family practitioner will need to know that.
Awesome. So you had talked about sleep a few minutes ago, and so it's a great segue into a related area. I have always chased sleep myself, but it became even worse after menopause. With a bunch of different strategies in place, it's become much better, but it's still an awful lot of work. And you mentioned a bunch of things that we'll get into in a minute. But how does menopause impact sleep specifically?
You want the good news or the bad news?
Like I said, I'm a realist, give it all up.
Okay. The bad news is that we really don't know why women not stop sleeping or have interrupted sleep during menopause. There's a whole bunch of hypothetical answers. And of course, the typical, well, it's hormones, dummy. Sure, it is hormones, but why are women experiencing such a problem either initiating sleep, but more often than not maintaining sleep? So chances are you're able to fall asleep and in 45 minutes you're up. It could be because you have a hot flash. It could be because that you're just uncomfortable. There's pain. There's spasms in spinal cord injury. There might be other situations in your room, your partner, or the environment's too hot, the environment's too cold, but those are not necessarily menopause related. In hot flashes and night sweats, that's basically a form of dysautonomia. And I would bet that our audience will be familiar with that. Is when your part of your nervous system goes completely berserk and your pulse goes out of whack, your temperature control goes out of whack, your blood pressure goes out of whack. So it might be similar. So when you put those two together, the autonomic aspect of control of our body, which is already affected in spinal cord injury, with the autonomic dysfunction that happens in menopause, it's not surprising that women with spinal cord injury will have a higher degree of these symptoms. It is possible that the hormones that start dropping during menopause might have to do with how certain hormones in our brains, certain neurotransmitters that foster sleep or arousal or awakening, start malfunctioning. It is possible that as the estrogen levels drop, the neurotransmitters in our brains that foster peacefulness, lack of anxiety, improved mood, preservation of sleep, start to become dysregulated, and hence sleep starts to become affected. It is possible that anxiety and low mood are affecting sleep. As I said before, pain can affect sleep. Now, restless leg syndromes, I'm not sure how common that would be in women with spinal cord injuries compared to the general population, but it is known to happen. And basically, it's a sensation that you have to move your feet, even though you might not be able to, or there's nothing in your feet that make you move them, but that's an uncomfortable feeling that you have to move them. And that is also a neurological, that's another brain problem that can happen during menopause. There are many, many causes that can make a woman not sleep well.
So, like, I also have had a lot of trouble with sleeping. Some days are okay, but other days it takes like hours to fall asleep, or I might be able to fall asleep and then I wake up and I can't get back to sleep. How could I tell if my sleep problems are due to menopause or SCI or something else?
It is tricky. So if the SCI happened before menopause and you were sleeping okay, and then you go in perimenopause, before menopause, and then menopause, and then your sleep gets disrupted, well, chronologically, it fits. If because of the spinal cord injury you had sleep problems before, that makes the insomnia worse after menopause. There's different types of insomnia: sleep initiation, sleep maintenance, or waking up too early in the morning, which I still consider sleep maintenance. Typically, if you have problems falling asleep, it's because your brain is not shutting down, among many other issues. But let's say you're not in pain, there's no urine infections, there's no pressure sores, your environment is conducive, your mattress is fine. If you have a partner, the partner doesn't snore, or you kick the partner out of the room. So let's say all things being equal. More often than not, it's because your brain is not shutting down. So one of the most common causes is because something is worrying you and you're trying to problem solve at a time when there's nothing to be done. You're in bed, it's 1 a.m, you look at the clock and it's 1:10, then 1:15, then 1:20, and then you start getting frustrated and frankly pissed off. And then your brain is not going to fall asleep because now you're dealing with anxiety and anger. To answer a question with a question is, does it really matter if it's spinal cord injury, menopause, or both? Ultimately, the symptom is there. Ultimately, is what you're suffering, regardless of whether it's one or the other or both. So If you cannot fall asleep, it might be that it's not a sleep problem, but a sleep schedule problem. You might be going to bed too early before your brain is ready to fall asleep. You might be going to bed perhaps too late because you were out having a great time and now your sleep-wake cycle is out of kilter. But more often than not is your brain is trying to solve problems. Your brain is trying to either think about what's going to happen tomorrow or what happened yesterday or that morning. And we call that rumination, which is anxiety, in other words. If your mood is low, you're not going to be able to fall asleep, both because psychologically you're worrying about something, you feel sad, but hormonally and neurotransmitter-wise, there are disruptions. That is very different than whether you wake up in the middle of the night because you have one of those massive typhoon-like hot flashes where you feel that you're burning inside out, which is very uncomfortable. And then you get all sweaty and within 20 minutes, you're freezing. So that is the hormonal part. And that one, we can safely say that you can sort of blame menopause with that. There are other factors that can contribute to waking up in the middle of the night, environmental issues that are waking you up.
Do you have any helpful tips for women who do struggle with sleep? I avoid caffeine, and I'm quite certain that that helps. I also try reading before bed because anxiety, for me, which you hit the nail on the head, is definitely probably one of my issues with trying to fall asleep. And you're thinking about all the things that you need to do, or you should have done, or you wish you did differently before heading to bed. But what are some other things that women could do?
So, Anita, let me pose this question to you. When you cannot fall asleep, usually what time would that be?
Well, it's probably late and past my bedtime.
Correct. Can you solve any problems at that time?
No,
If you get any thoughts that are anxiety provoking, can you solve them at 3 in the morning?
no, but I often think about what I'm planning to do for the next day.
But that is solving. You're not solving. You're just easing off your mind, but you're not solving anything. So the idea is any thought that pops up between midnight and 6 a.m., automatically ignore it, especially if they produce anxiety. What else can you do? You're already doing the caffeine thing. Now, caffeine comes in many shapes. Could be coffee, could be tea, could be energy drinks. So you have to be mindful about that. Caffeine usually is out of your system between 4 and 8 hours, depending on each person and how strong the coffee is, but sometimes longer. So no coffee after noon, 1 p.m., that's okay. The second thing is limit the amount of fluids you drink after 8 p.m. A lot of people drink a glass of water before bedtime. That's a no-no. Try not to eat after 7 p.m. When you're eating and your body starts processing foods, that might affect your sleep, especially if they're very fatty or spicy foods. Avoid alcohol. That's another of my pet peeves. Alcohol is a fantastic neurotoxic agent, first of all. Second of all, the perfect recipe to fall asleep and wake up in 3 to 4 hours is alcohol, as any teenager or grad student will testify. 4 hours, you're up, and then you're fully up. So alcohol is very disruptive to sleep. Sleep medications, over-the-counter sleep medications, work for a couple of days, maybe 3, 4 days, but they start lose efficacy and people start upping the dose. I'm not going to say commercial names, but you know which ones. They typically are antihistamines, not advisable. Screens. How does our brain know when it's daytime? Well, our eyes start getting light, the retina gets the message, melatonin starts getting suppressed, and an area of the brain called the reticular activating system starts getting activated. So that's one. Temperature goes up. Our body temperature starts rising. We eat, and then the sugar spikes, insulin gets secreted. Noise wakes us up. Now, what do people do these days before going to bed? We are in front of a device that shines a light in our eyes at 11 o'clock at night. We might be eating chips, drinking a bit of a soda, while watching something really scary on Netflix or whatever thing you're watching on YouTube. Perfect recipe for not sleeping. So no screens, 30 to 45 minutes before bedtime. Your bedroom should be cool, dark, and bed should be for two things. One of them is sleep. The other one, I let you to guess which one it is.
Snacking?
Of course, wrestling. Wrestling, absolutely. Which, by the way, sex is a fantastic sleep aid. Doesn't have to be between two people.
It's sex with the person you love, right?
It's pretty much it. It's not the sex itself, it's the orgasm. So whatever ways you can get there, fine.
Okay, so again, you lay out some really great practical solutions. And I know for me, the alcohol reduction was stunningly easy in terms of once I saw how badly it affected my sleep, reducing it almost entirely to nothing was pretty easy to do. And luckily, my partner was really good about joining me in doing that. And then getting my hot flashes sorted out. And then I'd love to say I'm strict with my sleep hygiene, but you just mentioned a whole bunch of things that I really love to do, which involve screens. So getting better with my sleep hygiene really worked. And then progesterone was helpful to help me kind of reduce some anxiety and get back to getting sleepy and into a sleep phase. When should I talk to a doctor about my sleep issues after we've heard about all these things that we need to do that are practical and doable? And once again, what should I be doing to help them help me?
Remember the secret I told you about what we physicians consider to be a disorder versus just symptoms? If you're not functioning.
Right.
So the moment you feel your function is not great, that's the time to raise a red flag. Now, I've neglected to talk about something that is extremely important, especially in spinal cord injury, which is sleep apnea. Sleep apnea is when we stop breathing in the middle of the night. So the typical snorer snores loudly, but there's no gaps in the breathing. So they sound like a locomotive, but they're still breathing. Some people, because of certain conditions, the back of the throat starts collapsing and blocking the airway. When that happens, there is a pause in breathing and the oxygen level starts going down. The carbon dioxide in our blood starts going up, and then they take a gasp. So it's like, at that moment, they went from deep sleep, not fully awake, but to superficial sleep. And that can happen many times in an hour, many, many times in an hour. So the consequences is that your brain never goes into a deep sleep and is never rested. That is another reason why people might not be consolidating sleep and might wake up feeling very tired, headachy, and fall asleep the moment they're not engaged either in conversation or any activity. That is very important because it is also associated with high blood pressure, stroke, and heart attack. So if there is no sleep partner, no bedmate, that needs to be studied through a sleep study, which might be tricky in a patient with spinal cord, especially a high spinal cord injury, because the sleep lab needs to have the equipment to transfer, but not impossible. So talk to your family doctor, to your practical nurse, to your registered nurse, whoever it is, about the sleep problems you're having. Blood work needs to be done. There are conditions that can produce insomnia, that can produce non-restorative sleep. A physical exam needs to be done. Make sure there's nothing else affecting your sleep function. And then talk about what's possible. Sleep medication should be the last resort.
Okay.
The first is to treat the underlying cause. So, for example, if Anita feels anxious because she has to submit a grant in the next 3 weeks and she's only halfway through it and is very stressed, putting Anita on a sleep medication might be a temporary solution, but then there will be side effects the next day. Dealing with what is realistic, what are the expectations, dealing with the anxiety is more useful. If you have low iron, as Dr. Craven wisely noted, that might be producing restless legs and affecting your sleep. If your thyroid levels are going up or down, that affects sleep, many conditions. So the first thing is to find out what is causing the insomnia. Is it sleep a maintenance problem? Is it sleep apnea? Is it that you're loading your body with fluids before bed and then you either have to empty your bladder or you feel wet? What is it that's causing for you to wake up, and attack that cause? Sleep aids should be the last resort. Oftentimes, we resort to mild, weak antidepressants that at very low dose are very safe to treat sleep maintenance problems. So people who have problems falling and staying asleep, and they're quite safe and commonly prescribed, but that is the last resort. Exercise. I'm going to go back to my exercise horse. Exercise, important.
Well, thanks very much, Dr. Steinerman. This has been a huge wealth of information for all of us. So I want to end things off by asking you what your take-home message would be, and what you want people living with a spinal cord injury who are experiencing perimenopause and menopause to remember.
Thank you for the question, Anita. Mood changes, sleep problems, brain fog are common, very common during menopause. Please, let's normalize it. Share your experiences with family, with friends, and care providers. Don't stay quiet, you're not alone.
Thank you, Dr. Schneiderman. So if you found today's talk interesting, check out our action planning tool on the website at www.scifragments.ca, and feel free to send us your feedback using the survey provided on the website.